still exploring palliative care. Today we have Dr. Zipporah Ali, who is the Executive Director of Kenya Hospices and Palliative Care Association. Karibu sana daktari.
Asante sana Wanja.
When we talk about palliative care, there's an aspect of pain. And in our discussion you had said, pain is what the patient says hurts. So what is pain and how would you categorize it?
I'll really define pain from a very simple approach that I've told you about. That pain is what the patient says hurts. So that means there are many things that can actually be hurting a patient who has been given a diagnosis of a life-threatening illness or a terminal illness. Pain could be physical, and the physical pain is usually the one that brings patients to the hospital because they're in physical pain, they need their physical pain to be addressed. Pain can be emotional, pain can be psychosocial, it can be spiritual. Spiritual is when people ask themselves, why me? What have I done to deserve this disease? When they have that, at a point of time in your illness, you even start hating your creator because you feel that they have been unfair to you. So there's the spiritual pain as well. And I always like to add, for African countries and the rest of the low and middle income countries, and even some of the Western countries, pain is also financial. Because we know that, for example, a diagnosis of cancer in this country a few years ago was like a death sentence because there was no access to treatment for cancer. And still even now, there's no complete access to treatment for cancer, even though NHI is now kind of supporting treatment, it's not 100% support. So pain can be from physical, emotional, psychosocial, spiritual, financial. Now, if I talk about physical pain, is when the patient comes and says, I have a pain in this part of my body or that part of body. Now, the pain could be for a sudden onset, what we call the acute pain, that will last maybe for a few weeks, and maybe at the end of 3 months you don't have that pain anymore. Or it could turn into a chronic pain, which you now have most of the time, and that's mostly the common pain that we see in patients with life-threatening illnesses. They have usually chronic pain. So somebody could have a cancer and the pain is in the site of the cancer, but also the pain radiates to other parts of the body and also is felt in other parts of the body where the cancer has spread. So when we are dealing with this pain as clinicians, we have to identify what kind of pain we are dealing with. Is it a sudden onset pain? What made it come? Is it a pain that has been there for a long time? What are the causes of this pain? What relieves this pain? Is it at certain times of the day? And all those things, we have to ask very many questions. So we really have to understand how to classify pain.
Is there a particular scale that you're able to grade the pain?
So once we know what kind of pain it is it a bone pain? Because we are going to treat it differently. Is it what we call a visceral pain? This is the kind of pain you'll have if you have, for example, cancer of the liver or of an organ in your body. Is it a nerve pain, which is usually a very complicated pain, which might come with feelings like sensation of numbness, tingling, So we have to really understand what kind of pain are we dealing with. Once we are maybe able to identify that pain, we also need to be able to understand what level of pain is the patient having. Is it mild? Is it moderate? Is it moderate to severe? Is it very severe? So severe that the patient cannot sleep, eat, or even talk. So we have to look at what kind of pain is this, and then what is the level of this pain. So we do have tools that exist that we can use to measure the patient's pain. They might not be 100% because the patient needs to understand how to use them, but we have simple tools that, like from 1 to 2 maybe is a very mild pain, this 2 to 3, 4 to, and then when you get to the 10th scale, then we know this is really unbearable pain. And then also for children, we have a tool that we can use the faces. A smiling face shows a happy child. Then you see the face changing as the pain becomes more, and towards the end, the face is a face of a crying child because there's no pain. So other people use different tools. I know in Uganda, they even actually talk to people in the village to just use their 5 fingers. I have no pain, I have very little pain, and when I do these 5 of them, I have extremely severe pain. So once we assess this pain, we know the level of the pain, then the next thing we need to think about is how are we going to manage this pain. And so that usually sometimes is the most difficult part of this whole thing, that a lot of times that our clinicians do not have enough knowledge and skills, have not been trained on how to assess this pain and how to escalate the treatment of this pain. So WHO has come up with recommendations on how to treat this pain for cancer patients, for example, which can actually be used for the other pains. And it talks about using the normal drugs that we use, for example, brufen, paracetamol, that we can use for very moderate pain. Those drugs will actually probably treat the pain. But as we spend more time with the patient, or the patient comes to us and says that this pain has not gone away, I'm still in so much pain, we actually can go to the second level of pain management, where we start using the weak opioids like tramadol, codeine, phosphate. And so once we give that to the patient, we review them again maybe 24 hours, 48 hours later to find out how their pain has responded to the medication. And if you realize that they are still in so much pain, they can't eat, they can't sleep, they can't live a normal life, then you go to the higher level, or the third step of the ladder, where we now give opioids. So opioids are medicines that are strong. They actually are used for severe pain and are very effective, and most times are quite safe enough. And the only problem is they're not easily accessible.
Okay, because they are prescription only.
They are prescription drugs, but apart from being prescription drugs, most countries do not even have enough opioids, because we concentrate a lot on the illicit part of these drugs and less on the licit, the medical and scientific uses of these drugs, which we need to also factor in our policies and everything. That despite the fact there is trafficking and all those things that are not right, we need to ensure that we have enough medicines. We have enough medicine for medical purposes and for scientific purposes. So at the level 3 in Kenya, what mostly we use is oral morphine. Okay. Yeah, oral morphine is cheaper than most of the other drugs. We have other drugs that are not available in Kenya. We have others that might be available but are very costly. So we actually mostly advocate that, which is very highly recommended by WHO as well, that we actually use oral morphine. Yeah, so if you've assessed the pain, the patient's pain, and now you have an idea of what kind of pain you're dealing with, if it's going to respond to opioids, if it's going to respond to the lower levels of the ladder, or is it going to respond at the highest level, you then start prescribing the medicines accordingly. And most times the opioids are not just by themselves. We combine them with other drugs, what we call adjuvant drugs. Sometimes you might need to give an opioid and a brufen. You actually have to understand the pathophysiology and everything else about this pain to be able to treat it. So once you treat with the opioids, most of the pain, 95% of the pain will go away. And that makes it bearable for the patient to even just be able to have a good quality of life. We might not manage sometimes to treat 100% of the pain.
But you manage
most of the pain. And that's the most important thing, because pain is devastating to the patient and the family members who watch this patient, in so much pain, and they also feel a lot of emotional pain. So sometimes you might treat the physical pain and you realize, I'm not really getting anywhere. The patient still comes to you and say, I'm in pain. Maybe they're not coiled up in pain, but they still sit and tell you, I'm in pain. Then you need to think holistically. What else could be bothering this patient apart from the physical pain? Do they have an emotional pain? Were they the breadwinners and now they are no longer able to support their families? Do they have a spiritual pain? Are they at this point of time having many questions for their creator or what they believe in? That why am I the one who has this illness? What did I do to deserve it? Is it witchcraft? All those things. Do they have a financial pain? You told them they need to bring, 500,000 shillings for treatment, and they're going through this. What will I sell? What will I do to be able to do this? We actually have what we call the total pain approach, that you have to approach pain from all these aspects. You might give as much morphine as you want, and you might not be able to control that pain unless you address these other issues. So that really simply means pain is holistic. Yeah, and it's a human right to be treated.
It's a fundamental
human right
yes.
that nobody should suffer from pain if we can treat it. So maybe one of the problems we should have, and even right now as I'm speaking to you, is we have a stock out of morphine.
Is the shortage in public hospitals?
The shortage is okay. Let me say at the public level, because what the last few years we worked with the government, with the Ministry of Health, with the support of the American Cancer Society and Open Society Foundations, to start a project that we call Treat the Pain. So Treat the Pain project has mainly worked in advocating at the government level to ensure that pain drugs are available and are included in the essential medicine list for medicine in this country, which has been done. And because of this advocacy, about 2-3 years ago, the ministry actually bought some morphine. about 52 kilograms of morphine. I'm not so sure, can't remember exactly if it was, I think it was 52 kilograms of morphine. They bought this morphine, and what we do with this morphine, we stock it at KEHPCA, and then from KEHPCA it goes to Kenyatta National Hospital, and the Kenyatta National team really constitute it into an oral solution, and then from there it is distributed across the country to all the public hospitals that are using it, to all the hospices, and even most of the mission hospitals. So we have run out of this powder because of well, we shouldn't even have gotten to that point.
It should have,
but government has a lot of bureaucracy. It has to have a tender, it has to go through so many things. So this has really is taking some time. It has been taken by events. So of course we've been promised that it will be available in the next 4 to 6 weeks. But meanwhile our patients continue to suffer. So we've had, for example, just now approached a well-wisher, Faraja Cancer Support, and ourselves put up our efforts to actually purchase 1 kilo to at least meet this gap, because patients' pain doesn't wait until the morphine is available from the other side. Yeah.